Hi everyone, Stefan here at Iron Direct Primary Care. I have a lecture for you all tonight at Chronic Disease Prevention and Management Group. One of the biggest lab panels I've ever done, about 217 pages long, which I've tried to synthesize with some aid of AI and so forth. And some of these panels, they do get a little bit out of hand, especially if you're adding up a few things in a really complex case. So I wanted to introduce you all to my sister. She's not here at this time, but I'll show you a picture of her. This is Belle here. It's my sister. Now, Belle, she has had chronic shoulder pain for some time now, a couple of years. She's played tennis, high school tennis, and she knew her shoulder hurt whenever she ate gluten. She knew that much. But she's 19. She does like to eat gluten on occasion. She goes to UCF. She's studying sports and exercise science. She likes to go out with friends. Her pain was getting pretty severe. I don't think her diet was the best recently in her studies at UCF, but the pain was so severe that I had to even put her on daily dose of hydrocortisone so that she could get through the day. I did some x-rays and it showed that she had a bit of an osteophyte in her shoulder, and nothing that would suggest she had torn anything, no fracture, no lesions or anything like that. Just a simple osteophyte, maybe some AC joint issues. But she knew it was gluten that was giving her an issue. Now, she also had some acne on her skin. Her skin is actually really nice right here. Her skin has improved a lot recently after our treatment. Now, I'll get into a little bit what we did, but first, the lab panel. So we did this massive panel with Vibrant America, pretty large panel, looking at everything from her lipids to her hormones, her genetics, her nutragenomics, her detox genes. So we can scan through a little bit here, and we can already see some hints of some issues in the what they'll call the cardiac health panel. And really, I'm not worried about cardiac health issues in a 19-year-old, but you can see some problems here. The HSCRP of 2.0 and a myeloperoxidase of 630, showing that she has some oxidative stress and she has some chronic inflammation. Other than that, her lipids are what I would expect of a young female. Typically in these lipid panels, the younger they are, the better their lipid panel. So I think we should be measuring cardiovascular risk markers in young children and teenagers so that you have a baseline. The reference range is, well, it's going to be what the general population is. So if you start getting a lipid panel when you're 65, you have no idea what it was when you were a teenager. And maybe the cardiovascular disease started when you were a teenager, but if you don't have the record, how are you ever going to know? And you have to base your results off the population and the reference ranges. So I encourage all my teenagers at the practice, get these labs done before you're age 65 and have an issue. So you know where it maybe came from or didn't come from. So she has a good genetic risk, so low risk for cardiovascular disease. Her LPA is negative. Her ApoB is 75, nice and low. Triglycerides are 55, which is optimal. Less than 60 is really nice for his athlete level. PLAC, which is a marker of endothelial damage, is very low. It's 162. And her homocysteine is 5, which is excellent. Very often I see high homocysteine in those who have the homozygous MTHFR mutation, which is what she has. But she doesn't have high homocysteine. But a lot of patients will have this if you check it later in life. Their homocysteine is like 15, 17, 20, God forbid. And that's associated with cardiovascular disease, stroke, and Alzheimer's dementia. Her liver kidney panel, everything here checked out appropriately, kind of what you would expect, optimal AST, ALT, sodium, potassium. Now, the thyroid panel, she has longstanding hypothyroidism. So we did labs a couple years ago, about 2 years ago, because she came to me because she was having hair thinning, brittle nails. And this was really accelerated after she went to Europe, stayed with some friends there, and she came back with severe COVID, very sick, probably the sickest she'd ever been. And ever since then, she was noticing hair loss, brittle nails. We did the labs. Her free T3 was about 2.1. Her TSH was elevated, her low T4, and she was suffering. So I put her on NP thyroid. So I put her on 90 milligrams of NP thyroid, and all her symptoms resolved. Her hair grew back, her nails better. We can see in the lab panel, we maybe overshot the mark a little bit, but that's kind of what you could expect if you take 90 milligrams of NP thyroid and then get the blood drawn maybe 3 hours later, it's going to be a little high. The other thing it flagged red was the reverse T3. It's 6. This isn't abnormal in someone using human growth hormone, which teenagers are using. They produce high levels of growth hormone, IGF-1, which we'll see later. Her IGF-1 is high. IGF-1 actually suppresses reverse T3. So a lot of teenagers, they have very good free T3 hormone. When they have high IGF-1, it suppresses reverse T3. When you have low reverse T3, the free T4 conversion goes easily to free T3. And so that's why oftentimes teenagers can get away with maybe suboptimal diets, iodine, selenium deficiency. If they have a high growth hormone, they'll still have good thyroid function. But even in her case, it was not true, and she needed thyroid replacement. And why did she have low thyroid hormone at age 18? You're going to understand that at the end of this lecture here, why this happened to her. Some signs here that there may be some B vitamin deficiencies. If you look at this, you say, there are perhaps some MCV abnormalities, MCHC, RDWs. And so sometimes when you see this, you think there might be some B vitamin deficiencies. Maybe we should get a micronutrient panel here. Immature granulocytes were a little bit high, so this immune system activation going on. Complete blood count. This looks at the bone marrow. This is, Vibrant's way of looking at the bone marrow production. This all looks appropriate. Human IGF-1 at 253 is appropriate where you would expect it if you're young and have high growth hormone. Typically, adults past age 30, you'll see an IGF-1 of 140 or below. At older ages, it might even drop below 100. Adult growth hormone deficiency is categorized typically below 100 or below 90. That's severe adult growth hormone deficiency. But in young children, the younger they are, the higher it is. So they can be age 16 or 15, and they'll have an IGF-1 of 300, 400. I've seen it as high as 580 in a 13-year-old. The ESR is normal, 1, perfect. That's a marker of inflammation. Sometimes it can be a hint that there's gut inflammation going on. Hers didn't give us any clue that there was a problem as far as ESR goes, but there was some issues. Her total immunoglobulins, this test has been added on by Vibrant recently. This was normal. And then we're going to get into some more esoteric things here. So this is part of their micronutrient panel. So we did the NutriPro with Vibrant. It tests her nutragenomics. So you can see the mutation if she has a heterozygous mutation, which would be positive plus and minus. And then it will look at the serum as well as the cellular. So serum is what's measured at the time of blood testing. So if you took a supplement, it's going to be in the blood. And the cellular looks at the 30 to 60-day average as far as white blood cell is, and white blood cell nutrient status. I'm going to skip some of this because it's actually not the chart that I like to look at. There's a better side-by-side comparison of some of these. We'll get to this a little bit later. Oh, here it is. This is what I like to look at. So you can see it very easily here at a glance. So the CoQ10 was deficient in the cellular. CoQ10 is a very important enzyme, very responsible for over 400, 500 enzymatic reactions in the body. Now, while she doesn't have a mutation for this, she was still deficient in CoQ10. Her amino acids were very good. She does supplement with whey protein and aminos. She is into sports and exercise science. That's her undergraduate at UCF. So you can see that's pretty good. But then when we get into some of the minerals and vitamins, we can start seeing some severe deficiencies. We can see the serum and the cellular in pretty much every one of these, including copper, magnesium, myoinositol, let's see, vitamin A. All these are deficient. There's multiple mutations at the vitamin A level too. I think she inherited that from her dad here, who's in the chat too. Dad has the same thing, multiple vitamin A mutations, which they may predispose you to some vision decline with age if you're not conscious about vitamin A, getting it from dietary sources. All right, critical for your eyesight. B1, multiple B vitamin suboptimals and deficiencies here. You can see thiamin's depleted. B12 isn't actually that bad. Serum's good. Cellular is okay. B2 is a little on the low end. That's riboflavin. B3, nicotinic acid, is very low. So B3 is your proxy marker of NAD, right? So your nicotinic acid, your nicotinamide riboside. So that can be a marker of your mitochondrial health as well. Pantothenic acid also on the low end. B6 pyridoxine also very low. Low levels of B6 pyridoxine, this can drive high homocysteine levels with age. It's also very important for your nerves. We give this to a lot of women in pregnancy because they're so nauseous and they're deficient in B6. Sometimes giving them B6 can help with nausea in pregnancy. B9, here's your folate. And so Belle has the MTHFR mutation here at the R18 spot. Looking at her cellular and serum status is actually not bad. She's getting some into the diet. Her vitamin C, her antioxidants, as you'll see recurrently here, are pretty depleted. So when I see super low antioxidants in people, that tells me that they probably have an inflammatory process going on. They're depleting themselves of the antioxidants. Also very important for your joint health. Vitamin C is essential for collagen synthesis. Vitamin A was adequate, even though multiple mutations on this. K1 deficient. Many women will get easy bruising. So if you have a woman, they bruise themselves, they bump against the table and start bruising. This is a K1 deficiency, poor clotting. And then K2 helps with preventing calcium plaquing in the arteries. K2 also deficient. Now, both of these, mind you, are fat-soluble vitamins, and you shouldn't be deficient in these. If you eat some K1 on occasion, K2, you can get it from uh, what you can get it from beef liver, of course, vitamin A, K1, K2, leafy green vegetables. Those all have K1 in them. So taking a fat soluble vitamin on occasion is enough to store it in your body. The other ones, like the B vitamins, the minerals, they're water soluble, so they're in and out of the body on a daily basis. And people with intestinal permeability, malabsorption issues, they can get readily deficient in these, which is what we'll see a little bit later. Her fatty acids indicate a diet of a standard college student. You could see that high omega-6, low omega-3, pushing her ratio towards high AA EPA. Pretty typical of your college students. Then we get towards the food sensitivity panel. Now, Belle kind of already knew that she had some issues with certain things, but kind of the striking things was the eggs, um, some artificial flavors. So it puts you at it gives you kind of a report here, things you should probably avoid. Wheat, she knew that. Green pepper nightshades, this is well known. You got to avoid sometimes the legumes, the nightshades, the dairy, the gluten. This is something that you can have patients do an elimination diet on their own. I'm gonna try to mute whoever that is here. Shell, can you mute who that is? I think that's Dr. Patel. Okay, let me just do this real quick. That's Patel, yeah. Sorry, Patel.
You're right.
I got her. I got her. All right. So this is their wheat zoomer. This is where the interesting part happens. We look, and with this wheat zoomer, we can identify if someone has intestinal permeability. So she has high zonulin, and she has high antizonulin and antiactin. This is pretty classic for the non-celiac gluten sensitive types. So she doesn't have the genes for celiac. We looked at that earlier. I don't know if we may have missed that. Maybe it'll show up later. She has negative celiac genes, but she still has gluten sensitivity, as evidenced by zonulin and antizonulin. So what do these do? These are indicators that the intestinal lining is disrupted and it's a leaky gut syndrome. And this means that further foods can cause reactivity in the body. A couple gliadin antibodies. So this is all parts of the wheats, different parts of the wheats, different types of wheats. She's sensitive to all these. And she knew this, but it's good to have it sometimes on paper for someone who, it's hard to give up bread. And if you think, oh, I don't know, maybe it's in my head, I have pain when I eat a bread. It's good to sometimes have it on a paper to prove it to somebody. Let's see. Here's a corn zoomer. So she was sitting down for popcorn one night and she ate popcorn. She had terrible shoulder pain the next day. And lo and behold, she also has a corn sensitivity. And it might just be from, the glyphosate they spray on the corn. She's created a problem with this. Who knows why, but she does have a corn sensitivity as well to the cornzyme. There's a bit of an overlap here. Corn wheats, corn albumin, corn globulins. There's all types of parts of the corn that you can be sensitive to and develop immune reactions to. The egg, unfortunately, also sensitive to eggs, egg yolk and the egg white. She never even knew that she had this problem. She wasn't getting a pain, but despite that, she still has a relative high reactivity to egg yolk and egg white. And that happens in the leaky gut syndrome. You keep getting more sensitivities to more foods over time. Egg whites, so we'll kind of skip through this. Soy, she also had an issue with the soy protein, even though she doesn't eat that much soy. Maybe she goes out to, unfortunately, Panda Express. She does like going out to Asian foods. They do cook with a lot of soy. But it's not like she has a whole lot of soy in her diet. This is probably from like, going out to Panda Express and Thai foods and putting soy sauce on the foods. Peanuts, she like most patients, if they have some sort of autoimmune issue, you should probably eliminate them of these common problems. Super sensitive to peanuts. She definitely shouldn't be touching peanuts. She just shouldn't be going to Panda Express. Most Asian restaurants will cook with peanut oil. So this is something that maybe you don't see. Like you order something, you don't think it has peanuts, but they cook with a peanut oil, and you're creating all this antibody reaction to yourself against the darn peanuts. And why are people so allergic to nuts? I mean, there's a lot of theories as for that. I spoke with my mold inspector recently. His theory is that a lot of the nuts sit around for a long time and they develop mold, and then you eat them and you're reacting not just to the nut, but you're reacting to the mold as well. So that's one interesting theory. And a lot of grains too may be moldy too. So, I mean, it might come back to the mold again. I didn't measure mold on my sister in this panel. We measured enough, drew enough blood out of the poor girl. Her milk score slightly positive for the milk as well. Unfortunately, the casein and the whey, she may have a problem with both. So that casein actually is kind of low, mild positive on part of the casein here. It just kept going on and on. Grain, definitely grains, multiple quinoa, sorghum, teff, barley, rice, right? It's kind of ridiculous. Like, what can you eat at this point? So I was getting kind of tired of this panel at this point, so I'm going to just switch to some other things here. The lectins. Yeah, okay, so this is kind of at a glance, all the positives, the non-positives. Like, how do we fix this? Like, why is she having all of this here? Just goes on and on and on. Nuts, nuts, nuts. Gives you kind of a guide too here as to what you can eat or not eat. She also had some like synthetic food sensitivities too. Like you shouldn't be eating synthetic dyes anyway. I think RFK is trying to get some of them out of the diet, um, but it's sometimes nice to put it on paper. Okay, environmental toxins. So we looked at this in her as well. And she has a couple interesting ones. I think she had some that I was exposed to as well. BPA, that is in the inside of your metal cans, like your Coke cans. BPA, it's like a plastic liner that they have in there, or your Starbucks uh, to-go cups. Try to avoid them best you can. What are some of these other ones? DMTP. Okay, it'll explain it here. BPA, we know that one. This was an antibacterial and antifungal agent in some soaps, detergents, toys, surgical cleaning instruments. So she does work as a medical assistant. She might be exposed to some of these chemicals in her job. I told her just to be a little bit careful, wear gloves on the job, so you're not absorbing these things transdermally. This one is found in again in dish detergents, emulsifiers, cosmetics, plastics as precursors. They persist in aquatic environments and moderately bioaccumulative and not readily biodegradable. They can take months or longer to degrade on surface waters, oils, and sediments. And looks like a slight bit of atrazine, not bad. I think Dr. Benoit Tano's in the chat. He'll be glad to see not too much uh, the atrazine here. Um, I don't think there's any safe amount of atrazine or glyphosate you can have, but lower is better. This one, glycine, is a marker used to assess mitochondrial dysfunction in genetic disorders. When glycine levels are elevated, it can indicate disorders of the respiratory chain, mitochondrial dysfunction, or genetic causes. Toxic chemical exposure may be one of the most common causes of mitochondrial dysfunction. So we're seeing this more and more in practice every day as mitochondrial dysfunction. And we can treat it. People do respond well to mitochondrial therapies, whether that's 5-amino-1-MQ, MOTS-C, NR drips, NAD, 5-amino-1-MQ, methylene blue. But people chronically will come into us with fatigue and they don't respond to TRT or thyroid hormone or B vitamin replacement. And it can come back to the mitochondria just getting plugged up with all these toxins we're exposed to on a daily basis. Diphenyl phosphate is an industrial catalyst and chemical additive and is the primary metabolite of flame retardant. This is a huge problem in our area. There's a lot of runoff from Patrick Air Force Base, or this is Star Force Base. In our area, they did a lot of fire hydrant drills and they would spray this foam to put out the fires in these drills. And since it's north of us, it washed down south and it contaminated all the water and all our rivers. And so when I test people for environmental toxins in our area, I oftentimes will find flame retardant byproducts in their urine or their blood antibodies. So not actually a surprising finding here. Perchlorate, she also had fairly positive perchlorate. It's a naturally occurring and man-made. It's a powerful oxidizing agent. It's mainly used as a propellant in rocket fuel. This is also a common thing I find around here. MTBE, I was positive for that as well. It's also a metabolite in rocket fuel. We are near the Space Force base. They do send rockets off all the time here. So it might be a hazard of living on the Space Coast is being exposed to rocket propellant fuel. It's also found in food packaging, so that's more likely too. It's accumulated in vegetables in the water cycle, in other parts of the environment, and it's classified as a human carcinogen. And it disrupts the thyroid's ability to produce thyroid hormones. I'd say thyroid dysfunction is the number one diagnosis we have at the practice at Iron Direct Primary Care. It's super common. I'd say most people have suboptimal thyroid. It's actually more striking to find an optimal thyroid without thyroid hormone replacement at my practice. Butylparaben, she had this one somewhat positive too. It's a common antimicrobial preservative in cosmetics, in makeup, moisturizers, hair care products, and shaving creams. I mean, I asked my sister to avoid these things when you can. I think a lot of these things that women are exposed to are toxic. I think that's probably why women have more hypothyroidism than men, is because if you go into a women's cosmetic cabinet, they have probably 20, 30, I don't know, 40 items, depending on the woman, where a man might have a shaving cream. That's about the most you can find in mine, and I try to get the best shaving cream I can. I mean, I wash my hair on occasion, but I don't really put that much stuff on my body. And that's what I found. Like, women have more autoimmune disease than men. This is well known. They have more hypothyroidism than men. Why? Why is that happening? It can be a variety of reasons, but the overall cumulative toxic burden, I think, is higher in women. Now, the pesticides thing kind of creeped me out here. She had couple of pesticides in her urinary metabolites, and the highest one was the DMTP. It's a metabolite of organophosphates, which are one of the most common causes of poisoning worldwide and are frequently used intentionally as pesticides. They can enter the body through the lungs or the skin or by eating contaminated foods. Even at low levels, organophosphates may be hazardous to the nervous system, especially for fetuses and young children. Repeated or prolonged exposure may induce impaired memory and concentration, depression, confusion, headaches, speech difficulties, delayed reaction times, nightmares, sleepwalking, drowsiness, insomnia. Um, so whenever I drive around here, I'm always seeing people spraying their lawns with these things. There's guys, they're wearing the mask, they're trying to protect themselves, but they're spraying these chemicals right on the grass. And we live on an island. You think there would be some law or legislation to keep people from doing this because it goes directly into the rivers. I mean, our rivers are completely dead from the runoff because the rain comes and it washes all the pesticide right into the Indian River Lagoon. All the fish are dead. The manatees are dying. Everything's dying in the river. You can't go in the river. It's toxic. But people keep spraying this stuff on their grass. You can't stop them. Even though we know it's carcinogens, it causes all the chronic diseases that we're exposed to these days. I mean, your patient practice is full of this: insomnia, irritability, headaches, confusion, speech difficulties, and this is all developmental disorders in children. Every pediatric practice is all they see all day. Not so bad in the phthalates and the volatile organic compounds, so not too bad there. That was her urinary metabolites. Um, let's see. PFAS chemicals. Looked at all that. Cool. What was her PFAS? So this is your plastics. You're drinking plastic water containers. You're gonna have all the PF uh these basically mega fluorides, I like to call them. They're carbon chain fluorides. They're very difficult to get out of the body. And they bind to where your halides would otherwise sit, like your iodine, your essential iodine. Um, but they're industrial chemicals and they get everywhere. Uh, PFOA is a synthetic chemical used in manufacturing industrial and household products. These things are absolutely everywhere. She had a couple of these positive, and that's not super uncommon. I tested my Culligan's water container. It's a big plastic jug, and it tested multiple parts per million of various PFAS. So if you're drinking plastic, you are consuming PFAS. They're permanent. They cause, I'll name a few things. They can cause endocrine disruption, right? The usual, accelerated puberty, liver and immune system damage. That's your perfluorotriidecanoic acid. Man, I did a good one there. And it's used in many consumer products, nonstick pans, stain repellent carpets, waterproof clothing, fast food wrappers, and firefighting foam. And then some other examples. Um, and it causes, look at this. Recent research shows reduction in estradiol levels and changes in Leydig cell function among young men. So this is fertility issues, and this is everywhere. We're all exposed to this. Now we look at her toxin genetics. So how well can she detox all this crap that she's exposed to as a young girl? She has a couple mutations, unfortunately, that make her a poor detoxer. She has the cytochrome P450 mutation, double mutation. And I learned about this even in psychiatry because a lot of drugs, they use this enzyme in psychiatry. Your body doesn't detox it very well, so you can get liver issues, or if you have, I mean, you do have a slow liver detoxification process in the first place. And so you can accumulate drugs if you take them, and you can get side effects from them. But other than that, you can accumulate some problems. So susceptible individuals must consume nutrients including beta carotene, vitamin A, vitamin C, vitamin E, manganese, copper, and CoQ10, which can help the liver detoxify toxins. And that's everything we saw in her micronutrients panel. She's deficient in pretty much every one of those, vitamin A, C specifically, and CoQ10. So all these things that help you detox things. What else does she have? She double positive for the GPX1 gene, your glutathione peroxidase. It encodes a vital antioxidant enzyme called glutathione peroxidase. And I don't think we mentioned it earlier, but she was also low in cysteine and glutathione. I kind of glossed over that earlier, but that was pretty important to mention. And here she has a genetic reason for this as well. So she's someone that needs to supplement with the antioxidants like cysteine. And if she ever drinks alcohol, she should probably do an IV push of glutathione. Um, Alpha toxin. This is an interesting one. So you had a negative. What is this? Is it interesting? Recent studies show that polymorphs need alpha toxin one. Interesting. Let's move on here. And for these toxin genetics, does explain some things. Oxidative stress profile. Okay, here we're going to look at the glutathione. So it looks at the mechanisms here. Let's see. Impaired antioxidant activity. She has the SOD2 gene that encodes mitochondrial enzyme superoxide dismutase, which protects cells from mitochondrial superoxide by converting to hydrogen peroxide and molecular oxygen. This function allows SOD2 to clear mitochondrial reactive oxygen species, thereby protecting against oxidative stress. The individuals with this double T genotype, they show impaired mitochondrial import of MNSOD, leading to reduced enzyme activity, decreased antioxidant protection, and increased oxidative stress. So they have to consume an antioxidant-rich foods, berries, nuts, unfortunately not for her, green tea, which I am currently drinking, some matcha, and avoiding processed foods. In her case, she does need to supplement more because she's not going to be able to acquire it from nuts. She's too sensitive to those things. Couple other ones, more for mitochondrial dysfunction here. Double T again on this one. The cat. This enzyme participates in antioxidant functions in the body. A mutation in the gene leads to decreased catalase production, resulting in excess ROS production. We saw that earlier in her elevated myeloperoxidase. So a buildup of ROS leads to increased oxidative stress. So you can either consume antioxidant-rich foods or supplement. In her case, it's going to be, again, supplementation. This one here, the GLUT gene encodes for glutamine ammonia ligase, glutamine synthase enzyme. Glutamine synthesis plays a role in precursor and synthesis of glutathione. Glutamine is also very important for your gut barrier, which we'll talk about a little bit later. Lower selenoprotein concentrations, decrease antioxidant activity on this gene. So it goes on and on, kind of exactly what we saw in her micronutrient panel, indicating maybe there's a genetic reason also for why she is low in all these antioxidants, not just the cumulative environmental burden, also genetic predisposition towards low antioxidants and poor detox capacity. So let's skip through this. I was looking at these issues here. Oxidative stress biomarkers. So you can look at the glutathione conjugate. It serves as a marker of oxidative stress due to its formation as a consequence of lipid peroxidation, a prominent outcome of oxidative stress. 4-HNE, a toxic and stable end product of lipid peroxidation, is produced when cells are exposed to oxidative stressors. In response to the elevated levels of oxidative stress, cells mount a defense mechanism to counteract damaging effects. One of the predominant mechanisms involved the conjugation of 4-HNE to glutathione, catalyzed by enzyme known as glutathione S transferase. This reaction results in the formation of GSHNE. The presence in cells signifies not only the occurrence of oxidative stress, but also the cell's efforts to neutralize the harmful effects of 4-HNE. So it's a useful biomarker of assessing oxidative stress, which we knew as well. This one's pretty high. This 8-nitroguanine, quite off the charts. Elevated levels of nitric oxide can lead to nitrative stress. It is a phenomenon of cellular stress owing to the increased production and accumulation of damaging reactive nitrogen species. NO reacts with superoxide to form a highly reactive peroxynitrite. Peroxynitrite can then react with guanine on the DNA to produce nitrative the DNA lesion. 8-nitroguanine is indicative of RNS-induced nitrative DNA damage. Chronic infection and inflammatory conditions can lead to elevated levels of 8-NO2G. This is believed to be mutagenic DNA lesion, which means it is capable of inducing genetic mutation. Owing to this, it is associated with various pathophysiological conditions such as inflammation, neurodegeneration, and cardiovascular diseases. Thus, urinary 8-NO2G has risen as a marker of RNS-induced nitrative DNA damage. Typically, nitric oxide supplementation is a good thing. It promotes endothelial function, good endothelial function. But this is a marker of perhaps cellular stress when it's at such a high level in the urine. Let's see, any other ones that are peculiarly elevated? Let's see. So she gets an oxidative genetic or an oxidative age of 36.58 years old, given age 19. So this is another one of those longevity age clocks, and we have some work to do. I think we can reverse this with some antioxidant supplementation. And there are some suggestions here of the vitamins, vitamin C, selenium, quercetin, selenomethionine, vitamin E, vitamin D. And I agree with all those. But the problem with those is that she was taking a multivitamin supplement. She was taking the twice daily multi by Designs for Health up until this test. And you could see she was deficient in all these things. So why might you be deficient if you're eating a fairly decent diet too? I mean, she doesn't avoid meats. She does avoid fish. She does eat fruit. But why is she so deficient? Well, we have to talk about the gut permeability, and that is next, I believe. And where's her gut permeability? Oh, we looked at that already. Yeah, so she has high zonulin, so she has gut permeability. So my theory is she is not absorbing her vitamins, she's not absorbing her foods very well. And you can see also her hormonal disruption here. She has very high cortisone throughout the day, high cortisol. Which, mind you, she was not on hydrocortisone for this test. She had stopped it for 2 weeks prior to the test at my recommendation because we were going to do stem cells on that day as well. So all of this is pre or post not taking hydrocortisone. Some things, as Dr. Halasa will be strong to point out here, is that she does have, unfortunately, the estrone dominance. She has a low progesterone when we measured it on day 21 of the luteal phase, and high estrone, unfortunately. Kind of mid to low estradiol, high estrone. She's converting in the salivary hormones to estrone, which is the more problematic estrogen. This can predispose young women to endometriosis. This can proliferative disorders, cysts on the breasts. And then when you combine that with a low progesterone, you don't have the inhibitory effect to the estrone. Now, her DHEA is a little bit on the low end for where I'd expect in a young female. Her testosterone is also a little bit on the low end there. And I can sometimes see that in those with autoimmune conditions, inflammatory conditions, is their DHEAS, or in their DHEA, it does go down as well. So what did I do for Belle? On that day, because of her shoulder pain, I gave her Audrey's stem cell injections. Oh, there's Belle. I gave her the stem cell injections in her shoulder, and I gave her an IV infusion of exosomes and Wharton's jelly. It was very expensive. It was at least like $2,000 plus worth of stem cells, in a hope to help kickstart her regeneration and healing. And at the same time, I put her on As Dr. Carol Peterson will like to hear, the Quicksilver Scientific liposomal vitamins. Vitamin C, CoQ10, they're all of them sublingual because she just was not absorbing your conventional multivitamin. It doesn't matter the brand. She's not absorbing it. We saw that in the labs. I put her on a gut protocol of glutamine and microbiome labs, total gut reset, and I put her on a peptide known as lorazepatide. It's a peptide uh, I think inspired from Vibrio cholera, the infectious disease. But this one singular peptide from Vibrio cholera, lorazepatide, it can repair the damaged epithelial lining of the intestines. It can repair leaky gut syndrome. So I put her on this peptide. I also have had her do cycles of oral BPC and KPV to help with gut inflammation. And we had her do elimination of gluten entirely. So the result of all this, and Belle's here, she can tell us here her experimentation. Belle, you can correct me if I'm wrong, is you found that the stem cells didn't do so much as avoiding gluten. Is that right, Belle? You can unmute yourself there.
There it is.
Yeah,
Yeah, yeah, I don't really think the stem cells have made a difference, at least so far. It doesn't feel any different than before. But
right.
as long as I don't eat gluten, I feel pretty good. Like I had a half of a spring roll like a few weeks ago and I felt a twinge of pain like the next day, but then I was fine again. So I have like a little bit of gluten, it'll hurt, but then a lot of gluten it hurts a lot. So
Right. And then you noticed something very interesting with the vitamins. Can you tell us what happened when you started using the sublingual liposomal vitamins?
yeah, I feel like I'm calmer, like less anxiety at like work and stuff, which is really nice.
Yeah.
Nice calmer throughout. Yeah.
And you said that the liposomal vitamin C, what did it do for you?
Pretty much, yeah, just helped with my like mental state. I feel like that's pretty much it.
That's
You went
good.
away.
And then I think your skin is improving too with all this.
Yeah, I'm also using that skin stuff that you gave me too, though.
Oh, we did a topical retinol, did we?
Yeah, it's like a topical retinol. It also has like an antibacterial or something in it. It has a few things in it. I think that's been good for my skin too.
Yeah, and we put you a little bit on biocidin as well, but you said your stomach rumbled a little bit too much on that.
Yeah, I'm using it still
Oh,
though.
okay. What
Yeah,
else?
just slowly increasing that.
Did we miss anything? You're doing the glutamine, you're doing the microbiome reset, lorazepatide, liposomal vitamins. Did we miss anything?
NAC.
Oh yeah, we recently put you on NAC and also the DIM detox.
You're sticking glycine with the NAC?
And then I also wanted you to start the DIM detox as well as Vitex. That's right, Vitex. So yeah,
Okay.
Vitex, you want to take that one, and you can cycle it during the luteal phase up to about 1200 milligrams to enhance progesterone production.
Okay.
Very good. So I'm glad we got you out of pain. We don't need to rely on hydrocortisone anymore, right?
Yeah.
Oh, that's good. All right. Now, we'll open it up the floor to any questions or comments, anything else you'd like to see me test for her. Dr. Patel, I'm sure, has some things to say. We'll soon do a retest.
Great presentation, um, Dr. Stefan. I wish if you send me all those lab, I want to see if my AI will come up with summarizing and maybe giving you all the reasoning and the clue and all that stuff, and possibly with analysis of the AI, it may be narrowing down exactly where is the main problem that lead to the inflammation. Have you done lymphocyte mapping cytokine profile for her?
That will be the next step is looking at her lymphocyte map and trying to modify that if that's still elevated.
You did already chronic infection panel, right? For
No, I haven't gone down the pathogen route yet. I probably should, but I like to go at the approach of fix the gut, fix the
Right.
nutrients, and they oftentimes then can beat the infection themselves.
So you did the redox and you did the metabolic. Now I
Yes.
think it's time to do the complete immune and check her regenerative status as well. But it seems like she also estrogen dominant syndrome, so she has problem with metabolizing her six hormones. Is that something she has?
Yes, she has the high estrone, low progesterone. So I think supplementing her with these vitamins, these B vitamins, will be critical. Fixing her gut, that will help with the metabolites, and then getting her on the DIM detox and the N-acetylcysteine that should help metabolize the estrone. Of course, iodine should be helpful as well for this too.
Prognolone for her will be, because of her age, prognolone will be good. Have you given her prognolone?
Yeah, if we look back in her salivary hormones, I don't think we tested pregnenolone, but I can measure that in the blood next time.
Yeah, because it will help to feed the whole six hormone, and then what you're doing is just helps to balance it, preventing estrogen dominant syndrome from going on. But lymphocyte mapping will definitely give us a complete understanding of her immune system if it's shifting somewhere, and the chronic infection panels will definitely give us some indication if she's free from any underlying bugs that aggravate the whole autoimmune disease. But I think she's more of genetic, but that genetic tendency of skewing the immune system, it will show up in lymphocyte mapping very clearly, especially when you come up with the ratios.
Yeah.
And based on that, you can
How
monitor
much
the whole.
money did you spend? How much money did you spend on all this testing?
$2,500.
Is it by Vibrant or what?
Yes, Vibrant.
And what did they $2,500 they provide you every
No,
test?
no, I paid it myself.
Yeah,
So
a lot of money.
Yeah. I gotta fix my sister. I gotta make sure she can go through medical school. Then she can come
no,
work for me. She'll
yeah.
she'll make it back.
So estrone and estradiol, how did you fix that?
We're working on that still. Her estrone had dominance, so low progesterone currently. So we need to work on that.
Just you gave the progesterone cream to fix the
No.
difference?
No, I have not done progesterone cream. I am doing Vitex chasteberry, and then we're doing the DIM detox by pure encapsulation. It helps with metabolizing estrone.
So you gave her DIM, you said.
Yeah, DIM.
And Vitac, what is Vitac?
Chasteberry, um,
Oh, that autoimmune has that or ortho.
many, it's an ancient herbal. It's been used for 1,000 years to help with fertility. What it does is it helps support progesterone in women who still have a cycle.
So do you use that also in your PCO patients?
Yes, you can use it in the PCOS patients as well.
And how many milligrams is the pill?
You cycle it, and through the luteal phase, they peak at about 1,200 milligrams. So they do 400 milligrams maybe on day 15, and they go up, 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 1,200 milligrams. Then as the cycle decreases, they decrease the dose until they stop it. So they do day 15 through about day 27, and they stop it.
So these Vitac pills, they say that 1 to 7 days, 7 to 14 days, just like the birth control pills?
Yes, just like they would take progesterone or a birth control pill, the Vitex, but it's more natural. It just helps support the progesterone.
Which company is it?
I mean, it's ancient medicine. You can get it from
Oh,
a
ancient
tree.
medicine.
Yeah,
Okay.
yeah. Any herbal pharmacy can make it, or you can get it anywhere. Mm.
And how did you fix her gut? With what doses did you give you? You
Yes.
mentioned that 1, 2, 3, 4. What specific things did you give?
Yeah, Belle, you're taking lorazepam. Was it 500 micrograms twice a day, right? I think so. Something like
Is
that.
it oral?
Yes, lorazepam is oral.
Yeah, I'm taking it twice a day. I don't remember the strength,
Yeah.
but probably.
Are you saying she should back off on the thyroid a little bit, go down to 60?
Potentially, as her thyroid continues to improve, we'll be able to decrease the NP thyroid dose. So maybe eventually she gets off it as we fix her vitamins and we fix her hormones. I think so. And her gut, of course.
Yeah, I think I like where it's at right now.
Yeah, no, you feel good. The hair is good.
Yeah, I started taking anti-thyroid with like lorazepam and some other stuff in the morning. I did that for like a few days. My hair started falling out again,
That's it, right?
so I had to stop doing that. But as long as I
Maybe
take it by itself, it's totally fine.
yeah, you have to be careful if you take anything that can bind or inhibit the NP thyroid, it will not work.
Yeah, now I just take it completely by itself. My hair was literally back to normal in like a day. It's crazy. So I like the strength that I'm at.
Yeah, I think she needs to continue taking it. She's not out of the woods yet on this.
So you think this this peptide, if you would have used BPC 157, that would have not helped her?
No, she had been on a BPC 157, KPV on and off for her shoulder. Uh, but I don't think it was doing much. As far as we can tell in the gut, her gut still has intestinal permeability from the zonulin, the antibodies. She still has leaky gut. Now, how to regenerate leaky gut, I don't think anybody knows. It's all theoretical. So we're using lorazepam, we're using the microbiome, complete gut reset. We're avoiding the gluten, the things that damage the gut lining. We did the stem cells. So eventually, I want to repeat the test and see if the intestinal permeability score has improved, but it remains to be seen.
Did you give her any immunoglobulin products, SBI Protect or something, which helps to heal the gut really well?
No, as far as modulatory, I'm looking at doing that. I'm learning how to do German microimmunotherapy, and that will be the next step. So we're going to run the lymphocyte map. We'll do the stealth infections as Dr. Halasa suggests, and then we're going to look at microimmunotherapy, getting that from a German apotheker. It's a stepwise process here.
Why do you think that the German microimmunotherapy would work as compared to the what is available locally, like SBI Protect or something similar to that?
How does SBI Protect work?
It is an immunoglobulin product and it helps anti-inflammatory effect on the gut.
Uh, Belle, I think you're taking an immunoglobulin like a colostrum, right?
Yeah, but it has a better effect than just the colostrum because it's a very high
Can I press this button?
high potency formula.
Ah, yes. Okay, I'll look into this SBI Protect. I see it now.
And another thing you mentioned about the glutamine, I mean, everything what you mentioned, how do you know that she did not have a candida problem in her gut? Or because if you give glutamine or anything with the sulfur, it just promotes the growth and does not let it heal. And you did, I mean, I may have missed it, but I did not hear anything that you have done to control the candida growth except giving some probiotics. But I think that is probably something to give attention because she has a chronic inflammation
Yes, you're right.
and
We'll
and
do
an
that next.
ongoing leaky gut. And if she has a thyroid problem, which is also very common with the issue, and mitochondrial dysfunction. So looking at all that picture, I think that should be also addressed.
Yeah, you're
Yeah, to
100% right.
make it easy, it's redox status of the patient, immune status, metabolic status, and regenerative status, and then the genomics behind all those four. And that would help to give you, if you go through this panels or the steps, you understand where it's being missing. If infectious, you can put it under redox or immune panel, toxicology under redox. But that gives you a complete picture to do that. And that's the reason my AI is being trained to cover everything that we are missing and also pinpoint exactly where is the main issue that causes her autoimmune. So I would like you to send me all her documents. I'll let my AI to summarize the whole thing and then pinpoint exactly the prioritized things that needs to be done first,
Yes.
and give you suggestions. Because the AI will definitely screen all the articles and publications out there related to her case and give you the abstract from all the brainers of the whole world. So we cannot compete the AI with the data that the AI has.
No, it's true. Yeah. I've been talking a lot with AI about this case. Here's her intestinal permeability score. And you're completely right, Dr. Patel. I do need to look and see if there is candida overgrowth. But again, signs and symptoms of that, that would probably be if you eat something that feeds the candida, you'd feel bloating, you'd feel a little worse. So this would be foods that are highly fermentable. Maybe even eating something that's good.
Even the gluten gives the problem too.
Gluten
Yeah, sure.
feeds it as well.
Okay, dairy, gluten, yeast-containing food. So which is like ongoing and perpetuates. And another thing, no matter what you do, the leaky gut, if you don't treat them for their sensitivities, food sensitivities, by not just avoidance doesn't work because the most common food. So you have to desensitize them and increase their tolerance, then you will be able to uh, downregulate that zonulin, all these antibodies, and will promote the healing. So in our program, the allergy testing and treatment is one of the very important part of the treatment. Sometimes, what you have done, like the food panel and all different Zoomers, yes, it has some importance, but I think putting the needle in the skin and look at what they are sensitive to and provide the treatment for it, it becomes very effective.
So you're talking about
You can do either the provocation neutralization testing, you can do the and the PN testing based treatment. And if you are not able to do that, then you can do the low dose antigen treatment. And this all can be taught without a trouble. But I think that it is very important that should be a part of the management because everybody talks about using this test, that test, but then there are certain tests that we are not doing. I mean, you can treat for, you may say, oh, well, these are the normal bowel flora, but there are sometimes abnormal balance of the flora microbiome. And that balance, and then they can, if they have leaky gut, then they can develop also the sensitivity to some of the um, bacteria in the gut, and you can treat them for that too, so that you don't have an ongoing release of the inflammatory molecule, which does not let the gut heal. And gut-brain axis or gut, there are a lot of different axes, and inflammation takes place, and then you have treatment-resistant cases. But really, they are treatment-resistant cases because we have missed treating certain parts.
yeah. We'll get on it. I mean, I did attempt to treat I do agree. She probably has bacterial overgrowth, candida. She
Yeah,
is on the biocidin. What do you think of the biocidin treatment for that?
it's good, but it's not going to help the heal the gut.
No, no, it doesn't heal.
I mean, she has to go the rotation diet, not eat the same food every day. That so that the body, I mean, she will have a less inflammatory reaction, less cytokines, less inflammation, and it will help to heal the gut. Avoidance of the molecules that she's sensitive to, and it can be anything. We have not discussed about the food additives, food colorings,
Yes.
um, and and so on.
the lymphocyte mapping cytochrome 5 will give you an understanding of her autoimmune disease, what it's in nature, what it is. Is it more allergic, Th2 dominant, Th17, or it's more of autoimmune Th1, where the cytochrome.
Dr. Halasa, it is very important for all that, but these all molecule Th17 dominant or IL-6 or IL-17 or whatever, but we have to see that what is the basic factor that is responsible for initiating all this cascade. And if we know the starting point, then we can prevent a lot of damage. And we know, oh well, we have a Th1 dominance, Th2 dominance, this dominance, that dominance, but that is the cascade effect. Where if we know that what is causing the problem in the gut, it is the food. It is the food and food and food. And so when we say food, we are talking about, okay, bread. Bread is what is bread? Bread has so many, 7, 8 ingredient by minimum. That is, and so we always blame the gluten because gluten being the first part, but then there are so many additives in it. And
Yeah.
we have and the yeast Saccharomyces, Saccharomyces, that can be also the factor which cross reacts and causes the inflammation.
Hmm.
And you can check them for the antibodies for that.
Well, Saccharomyces boulardii can help find out a candida overgrowth too, right?
Yeah, but in essence, it will not do that because it is the sensitivity we are talking about. It is not just the imbalance we are talking about. If you are sensitive to the Saccharomyces, and that is the part in the one of the yeast problem, then there is a problem with the antibodies. And if you have antibodies, then you know there will be ongoing inflammation.
Yes.
So then the avoidance comes in the picture, and the treatment for the sensitivity.
Right.
So
What I'm just trying to say is that the rheumatoid arthritis, there's two kind of rheumatoid arthritis. There's Th1, Th17 dominant arthritis, and there's Th2, Th17 dominant arthritis. Now, Th2, Th17 arthritis is more linked to allergies, more linked to food, and all that stuff. So I want to see that. So we know it's a Th2, Th17 problem. Then it's her problem is more allergy than more into the genetics that leads to Th1, Th17. So the autoimmune of Th1, Th17, it may have some aggravating more with chronic infection or panel, but when it comes into food and allergies, you will see, and mast cell activation, you will see it there in Th2, Th17. So that gives me just an understanding she's more of environmental reactive versus from genetics of her body, that leads to more of Th2, Th1, cytotoxic T cells. And I think that helps to know exactly we need to focus on desensitize her. She has more of allergic Th2 dominant with some Th17, and we need to focus on that and trying to shifting it doing what you're talking about, detoxing and avoiding plus desensitization.
I like the idea of desensitization, like how to actually do that though. Like practice.
that's another field of medicine that we have to explore.
Yeah. I am going to learn
And
it.
I mean, I can have the classes and we can have the teaching courses. So I mean, we have to find out how many people are interested in this.
Well, I'm going to study it. I'm studying the German microimmunotherapy, and it is a form of a desensitization
Yeah.
procedure.
Yeah.
Well, desensitization, whether if you find a company will give you all of her, you give her the testing, those antigens, and they can formulate it into injectable through a compound pharmacy, and then you start giving it subcutaneously in a low dose. So that's a desensitization through antigen. And then you need to know if they are Th2 dominant, Th17 dominant, then you give her all the drugs that helps to inhibit those things and shifting it into Th1. So it's really lymphocyte mapping, cytokine profile, and allergic testing, and then coming up with exactly all the list that she's allergic to, and see if there's any compounding pharmacy can create a cocktail for her to desensitize her.
But you know what you get it on the blood test is not the same when you do the skin test, because it's a skin test you are injecting and you're injecting and into the connective tissue matrix, and their mast cells are there, interactions are there, and so there is a neuroimmune mechanism goes there. There are C fibers effect is there. So it is not just the mast cell activation. It was there is a central also activation. And some patients immediately you inject something under the skin, and patient goes and in the convulsions, or patient develops the tachycardia, or person develops the irregular heart rhythm. So it is not the same thing as what you are ordering in the blood test. Blood test is more like a screening panel, but it is not the super diagnostic panel that you say, oh, well, the blood test didn't show that she's allergic to that. That's not so, because when you take the history, and that's why the food diary is very important for 14 days. Every piece what they put in their mouth, and what time they put, and they cannot have 10 food at one feeding. They can have one food at one feeding, or a very single food, and you give them. So if they do not have any problem, does not mean that they're not reacting. Sometimes you require 2-3 doses over 2-3 days, or you feed the same food for maybe 5-7 times on the same day, and then they are reacting or not reacting. So it's a lot of clinical involvement is there. And by just doing the immune microtherapy, what you're talking about, I mean, I don't know much about that, but if they are just using the organisms, it's not going to resolve the problem. You're going to probably solve some inflammation, leaky gut, and etc., and secondary effect from that.
Yep. Well, that'll be my next lecture. I'll bring you guys the German microimmunotherapy results from all this. But great. Any other questions, comments before we close it down? No. Okay, good. All right. Thanks, guys, for.
Wait. Since we're doing a CME, I turned off the recording. So maybe we can talk some off-topic questions.
This whole thing's been off topic. I don't know if it
I know,
qualifies
but
for
it's been
CME.
great. You did a great job.
All right.
Okay, we'll end it.
All right. See you, Shell. See ya.
Okay, so.
Bye, guys.